Okay, so we all know that hypertrophic cardiomyopathy can kill a patient suddenly. The first symptom of hypertrophic cardiomyopathy can be the sudden cardiac death, secondary to ventricular arrhythmias. So, what is the overall risk of sudden cardiac death in the general HCM patients? We all know that it is 1% per year, but we can subdivide into high risk, low risk HCM patients based on different scoring systems. But somewhere it ranges from 2.8% per year to 10% per year, especially when ICD have come into play. We now know after interrogation the risk somewhere stands between 3 to 10% per year. So this is what I am saying. Among the patients who have been implanted ICDs for primary prevention, the ICD shock rate is around 4%, whereas the patient has undergone for a resuscitated arrest, secondary prevention, it's somewhere close to 10%. So how do you know whether a patient comes in high risk or low risk? This is a well-established criteria, either a resuscitated arrest, documented VT or VF, syncope with high suspicion of ventricular arrhythmia, that is unprovoked syncope, not on fasting state, all those things. Then history of hypertrophic cardiomyopathy related death in first degree relatives, LV apical aneurysm, and septal thickness more than 30 mm. Then this hypotensive response, and of late they have added this MRI replacement fibrosis more than 15% in cardiac MRI. So this is the algorithm goes like this. So now guidelines, both American and European, they have a very established guidelines to recommend ICD as class 1 and class 2 recommendation in this algorithm. So this is one of the classical, you may miss out this LV apical aneurysm on a casual echo, but with contrast echo and other cardiac MRI, you can pick up this LV apical hypertrophy, and which is associated with high risk of VT, where you can do ablation or you can put in an ICD or in some patients both. So coming to the proper topic, so we know that in patients with hypertrophic cardiomyopathy, the first and foremost treatment is a well tolerated, maximally optimized guideline directed medical therapy in the form of beta blockers. Then second line agent disopyramide can be used, which was not available frequently, but now again it is available. So once this patient medical therapy has been exploited, and since some of the patients are still symptomatic, we can consider surgical myomectomy and alcohol septal ablation. We all know for sure, like what is LIMA to LAD is here, surgical myectomy is the gold standard. Only in patients who cannot tolerate this surgical myectomy or in areas where there are no surgical expertise, then alcohol septal ablation should be considered. Why is so? Because we clearly here, you can see in the left side of the panel, when you compare myomectomy with alcohol septal ablation, the LVOT gradient always stay higher for alcohol septal ablation, both immediate post-procedure and short and long-term follow-up. Why is this important? Because post-procedure residual LVOT gradient or the increase in residual LVOT gradient over the follow-up is associated with increased risk of ventricular tachyarrhythmias and increased risk of sudden cardiac death. And we also know that this surgical myectomy has been performed from 1973 onwards, and the surgical experience has been robustly better when compared to alcohol ablation, which started somewhere around in 2000s. So we may think that surgical myomectomy may be associated with extensive scar, but it is not so. It is the alcohol that produces heterogeneous scar, and the quantum of scar produced by alcohol septal ablation is larger when compared to surgical myectomy. So it is this disorganized increased quantum of scar that predisposes to increased risk of ventricular arrhythmias in patients undergoing alcohol septal ablation. Whereas this figure clearly tells in post-myomectomy, you can see there is no much scar when compared to the alcohol-induced scar. So this is very, very important because studies have shown that alcohol septal ablation is associated with 2 to 4-fold increase in ventricular arrhythmias and related increased death. So what is how do you quantify the quantum of infarct is somewhere around 20 to 30 grams of LV mass can be infarcted by alcohol procedure. It is overall LV mass 15%, 10 to 15% of the LV mass, or if you take the septum, 1/3 of the septum can be infarcted by our alcohol procedure. So what is the mechanism? The mechanism is both myocardial necrosis and myocardial fiber disarray that leads to re-entry. Also, there are some studies that show triggered activity also plays a role here. Here we can see the fibers should be longitudinally and parallelly it should be arranged, whereas in HCM per se, the disease per se, there is a myocardial fiber disarray where 90-degree disorganized placement of fibrils leads to increased arrhythmogenicity. And when you add a component of necrosis induced by alcohol, I think the arrhythmogenicity doubles in patients with HCM. So we are creating one disease in the process of treating the other. So this is the mechanism of it is primarily re-entry, and in some of the studies they have also shown triggered activity. So because of this disorganized alignment of the sarcomeres and myofibrils, there is non-uniform anisotropic conduction, and there is increased apical to basal gradient. Also there is associated dispersion of the voltage, and ventricular activation is also not uniform. All this leads to re-entrant modes of VT. So this we have already seen that in patients undergoing alcohol septal ablation, there is the ICD intervention rate is somewhat higher, like it is 2.8%, whereas in patient with HCM it is only 1%. So we can pretty sure we can say that alcohol septal ablation increases arrhythmogenicity in patients with HCM. That's why since it is easy to do, alcohol septal ablation should not be done in all patients. It should be done only in very, very selected patients who cannot undergo surgery or who have high risk for surgery. So these are the complication rates compared with myectomy to alcohol septal ablation, and for here, except for mitral valve replacement, except for the comorbidities associated with this extensive surgery, the myectomy scores better compared to alcohol septal ablation. So here, they have very clearly shown that patients undergoing alcohol septal ablation has 5-fold increase in the increased risk of achieving the primary hazard event rate. So it should, so they say that it should be carefully selected, as it has not only it has a short-term side effect, it can have long-term side effects as well. So even the Kaplan-Meier survival here clearly shows that. So during the follow-up of 10 years, you can see here the curve starts separating from first year onwards. On myectomy, the benefit stays way ahead and the curve remains separated over a period of follow-up. Again, so as we all know that alcohol is injurious to health, the more amount of alcohol you use, the more harm you are going to do over a period of time. So you may be more, you may not know that giving an additional ml, you are actually producing more harm than good in such patients. So this is one of the classical VT seen in patients with post-ASA. Luckily, this patient on ICD and got successfully DC-verted. Here, this table is showing, so this you can see 11:1 increased risk for arrhythmic complications. Overall arrhythmia complications are 11 times higher in ablation when compared to myectomy, and appropriate ICG shocks, they are 8 times more common in ablation. Also, the sudden death rate associated with the ASA is 25% greater when compared with myectomy. For all these purposes, so we should take with a pinch of, not with a pinch, with a cup of salt, that ASA should be reserved only for very few patients, right? So this is the nutshell which I have shown that this is the lot of series, registries, initial series, they have thrown a lot of dangerous signals, but some later studies they show that the risk of ICD shocks are not greater in patients with alcohol septal ablation, but we have to be very cautious. So again, this is one of the papers in 2014 where again they have shown that septal myectomy should be considered as the gold standard. Coming on to the other arrhythmic complication of alcohol septal ablation, that is AV block, the incidence or the transient heart blocks occurs in around 1/3 of the patients. So the procedure is always done with a temporary pacemaker implantation, whereas the permanent heart block can vary from 6.5 to 11%, whereas we know with myectomy it is somewhere around 1 to 5%. So AV block is also more common with alcohol septal ablation. So what is the mechanism of AV block? We all know that interruption of blood supply, because we know that we are going to go through the septal branch, the largest septal perforator, which is going to produce right bundle branch block. So patients with predisposed to conduction system disease like pre-existent LVVV or pre-existent first degree AV block, they are more prone for developing AV block. And there is also direct necrosis of the myocardium and adjacent conduction system tissue, and also the associated edema. All this are responsible for the AV block. So but during surgery there is a clear visualization of the septum, and the surgeon can better understand the anatomy compared to the interventional cardiologist, because though we do under fluoroscopy and whatever echocardiograph, contrast echocardiogram we use, still we are blinded, whereas the surgeon has a superior vision compared to a cardiologist, and hence the risk of AV block is always lesser in myomectomy. So we know that it's a bimodal presentation. The majority of the patients, they develop within 24 to 48 hours, but some patients they can develop in 5 to 7 days as well. So some they call it as acute heart block if they happen on the table, and some they call it as subacute complete AV block if it happens outside the table and more than 24 hours. And even if patients have a pacemaker in situ, and if you are doing this procedure, still these patients can go for AV block because of the multiple reasons. And PR prolongation and pre-existing left bundle branch block and age more than 60 years are notorious risk factors for intraprocedural complete AV block. So these are the epidemiology. So we can see here AV block type 3 has developed in this series in 46% of the patients, whereas recurrent AV block was seen in 16% of the patients. Overall, 7% of the patients required dual chamber permanent pacemakers. So majority of the patients, as expected, they develop right bundle branch block during or immediately after the procedure. So in myectomy series, 1 to 5% of the patients require permanent pacemakers, whereas in alcohol septal ablation, from series to series it varies, and it's somewhere around 5 to 30%. Again, we see here there is a scoring system. This is an elaborate scoring system where the score is less than 8, it's a low risk. In low risk patients, none of the patients required permanent pacemaker, whereas if the score is more than 12, then 87% of the patients required permanent pacemaker after alcohol septal ablation. And this scoring system is made easier by this 5-point scoring system, which we can always remember: age more than 50 years, pre-existent left bundle branch block, and during procedure if patients develop high degree AV block, and post ASA if PR parenteral prolongation more than 70 milliseconds or a new onset biphasical block. If it is more than 4 points, then high risk; less than 4 points, low risk. So one more arrhythmia that can be seen after alcohol septal ablation is atrial fibrillation. Though it is not directly related to alcohol septal ablation, we may think that by reducing the quantum of septum and septal burden, we can bring down atrial fibrillation. But in series and studies, it is shown that no, despite reducing the septal thickness, patients continue to develop atrial fibrillation. That is around 8% of the patients. So I think I will end my talk here. Thank you.